All right. Looks like we are recording and up and ready to go now, so.
Yep. So that way you can see. Fantastic.
Okay. Just name and department and we'll be able to get this one going.
I'm Jen Sumter, Director, Webster County Health Department. I'm just going to start with the general supplemental budget, expenses only. We budgeted for 500 just for sheriff transportation. And then the 10,000 for any court committals, which is usually $60 a piece that goes through our office that pays that up to 10,000. That's it for general supplemental. We'll move on to rural services or environmental health. Allison put this budget together. Sewage disposal permits, we budgeted for 12,000. Well water permits, $2,700. Pool inspections, 5,000. Tattoo inspection, $2,250. There's no longer any tannin inspections. The effluent sampling, we've got 180 budgeted, and then well testing and abandonment is 45,000. That was a total of 67,000. You'll see over here, we did try to balance the budget, and we're thinking we needed another 35,000. The nice thing is I just signed an amendment on January 2nd for 60,000. So we'll be sitting really good on the revenue side of things and environmental health. As far as expenses, we just put in the previous salaries. Pretty much, I think everything was close to the same budgeting for. Sorry, just trying to figure out where I'm at here. Office supplies at 1,000, effluent sampling, 120. Advertising was 3,000. I was noticing on the mileage and sustenance or whatever line, she had that budgeted for 1,000, and I think we were trying to balance it, so we'll just have to make that correction because I only had $79 in there, just so you know. And postage, we had around $1,000. School instruction, she thought maybe around $2,000, and then well permit closing around $39,454. So that made that tried to make it balance at 102,788.
Sorry, your guys' worksheets don't show the same as Jen's. I changed something on the salary and need to get that adjusted again. So yeah, yours. I may have done a couple errors when I typed up your worksheets, and I'm noticing that right now.
You send that.
That was on which line you said?
Rural service basic, the salary, FICA, IPERS, Blue Cross, some of that stuff needs to get updated.
Go ahead.
Good. Okay. I'll move on to the public health fund. As far as revenue, the child health Title 19, we budgeted for around 40,000. If you kind of look back over the last 3 years, I think we were overshooting as far as what we thought we'd get for revenue. But we looked into doing ASQs, or ages and stages questionnaires, that look for developmental delays basically with our young folks. We think we can generate some more revenue there. About 3 years ago, we were doing it on every single kid, and it was a duplication of services. And we decided that we needed to do more gap filling services because obviously that was being done at doctors' offices. Typically at the times kids were getting their immunizations. So we think we can get more revenue there with thinking around $40,000 of revenue. We just started doing those actually last week at our WIC clinics. So hopefully we can see some successes there of increasing some revenue. Our maternal health Medicaid revenue, we're looking at 15,000. It might be, let's see, what am I looking at? You close that. I guess this is what it is right now. Pretty much on target. I think these numbers are probably from 2 to 3 weeks ago when Crystal originally sent that. So I think we're pretty much on target there. Our general assistance, I can't see this. Did I increase that? Or did we keep that? I think
let's see this
at 20,000. Is that the same? Okay. And then Title 19, home health. we went way down on this, and I think we're a little behind, obviously, on some of our billing, because we're only at 39,000, but I see us catching up, I don't think to 300,000, but we budgeted for 250. Medicare, we see a significant decline in what we think we'll get for revenue there. The vaccine was not going to make us any money. In fact, it'd be a money loser for us this year, so we decided not to provide any COVID vaccinations. Flu has gone down significantly as well. If you see in advertisements, pharmacies, different places give incentives for flu shots, so we don't get near the influx we used to. We can look at maybe having a drive-through clinic. We didn't do that this year. We can maybe see a little more revenue next year. But honestly, nursing homes are doing their own immunizations now, so that's been significantly less that we've been able to get for revenue. Nursing service fees, the local public health grant, it went from basically non-population health to population health, and the population health just covers essentially our salaries. So we used to have a sliding fee scale that we could provide some in-home services. That's since gone away. Again, the COVID and flu, we're not getting quite as much there, but I think hopefully next year there's a little opportunity. I don't think so with COVID, but we are looking at opportunities with our CPR program, maybe getting out there with some of the businesses in town. I think we could generate some more revenue there. I think we're kind of missing the boat there. We lost some staff, so we've got to get people retrained, obviously, to provide that as well. Hawkeye, a lot of these are just going to be pretty much what the grant is, how much it is in Iowa grants. So Hawkeye's 50,000, lead 15,781, the immunization program 11,200. Same with WIC, the 613,000. ABC Dental covers our iSmile program, our sealant program, varnish program, basically being in the schools, providing a lot of those services through grant funding. And then the child health grant at 165,000. Same with maternal health, 90,829. Childcare nurse consulting, that did go up slightly this year. That's another reason we're trying to hire another nurse. There's more requirements with childcare nurse consulting, basically going into daycare centers and providing, safety education, medication education, different things like that. So that's gone up, and that'll pay for approximately half of what the nurse would be, probably be around a 0.4 FTE is what we're anticipating. Skipping down, sorry, my vision's not great. The abstinence program, so our teenage pregnancy prevention program is at 55,000. Elderbridge, we've gotten 5,000 the last 2 years. We've again gotten 5,000 this year. We haven't been able to tap into that. There's a lot of eligibility requirements that we can't necessarily meet. One, they have to be 65 years or older. I have reached out to Elderbridge to see if there's other opportunities, maybe through our personal care assistance program. We think we could meet more needs there. But unfortunately, they've only allowed us to be able to offer homemaker services, and we've been unable to spend that money the last 2 years. Public health nurses grant is at 90,948. And then the spots. So in other words, our STI, HIV, hepatitis C grant is our spots program. And then Care for Yourself is also in there for the breast and cervical cancer screening. The next line we did have from the General Basic Fund. We worked on this quite a while. We do think we will need about 250,000 transferred into our account just because of some of the shortfalls that we've had. I'll be talking a little bit more about some strategies I think we'll have in place probably when I get done here, when you guys have questions. And then our bio money, basically our public health emergency preparedness and our hospital preparedness at 382,242. And then miscellaneous reimbursements at 10,000, which I don't think we spent that yet, but I know Shanna had mentioned that she could have some revenue in there that she could utilize. Okay, so that leaves us at a revenue of 2,976,727. On the expenses side of things, So our Title 19 to our subcontractors, what we have to pay out, again, we're in a service area of 7 counties, so paying out to those other 6 counties, we anticipate it to be about 50,000. MAF, which is our Medicaid administrative funds to any of our subcontractors, we anticipate it to be around 30,000 in expenses. Salaries for child health grant to subcontractors at 25,000, which is the same as what we did last year. We increased slightly, it looks like, on our wages too for our child health interpretation. A lot of our counties have a very high Hispanic population, and we are actually employing and subcontracting with some of our interpreters, so we anticipate that being a little bit higher. Maternal health grant to subcontractors, we kept that the same, around 10,000, which I think we're pretty much on target on that. And then maternal health interpretation, I think we're right on with that too. We went a little bit lower on that from 750. WIC grant to our subcontractors, it looks like we decreased that slightly too. We were probably a little bit under on that, so we took that down to 75,000. And then a maternal health, oh, that skipped. Sorry about that. Maternal health contracted staff, it looks like we did increase that just a bit. We've had to cover on some of the other counties a little bit more because they've had either staffing shortages or whatever the case may be. So typically we can send some of our staff to cover some of those other counties, especially Hardin County, who doesn't typically have a lot of staff. So we've had to send our staff there to cover a lot of services. We no longer contract them with our child health services as well as Hawkeye. So our staff are having to cover a lot of those services in that county.
Those are getting reimbursed or no?
Yeah, then they would come back to us instead of actually contracting it with the county. So we actually get the reimbursements for providing the services in their county. Nice thing is we can be kind of creative and not necessarily have to drive there, do mileage. We can do mailings or phone calls, different things we can do for outreach and that kind of thing, which is nice. As far as salaries, be working with Crystal. When we were looking at these salaries, I don't feel like people were in the deputy slot where they needed to be, or clerks. And other help is just dental folks. So you will see that all of our salaries on every area there has gone down probably around 40 to 50 each. There's going to be a little bit of a skew, just so you know, because of the fact that we thought we put the right people in the right line item, I guess I would say. We are in the deputy line. So we have the hospital preparedness, which is the HPP. We've been unable to fill that position because if you remember Tyler, he was the last one to actually hold that position. That typically is a requirement to be a full FTE from the state. Luckily, they've been able to work with us, and we've been able to do more of a 0.5 with our FEP, or Public Health Emergency Preparedness and Hospital Preparedness. We did not budget for that. With everything being so much in the air with, everything going on with the government right now, there was some possibilities that HPP may go away. I don't know if it'll go away. I feel pretty strong that public health emergency preparedness will stay along with the EMS side of things, but we did not budget for that particular salary. And then iSmile Silver, it's got a really weird grant year that goes from November 17th through November 16th. So that just started a couple of months ago. Our iSmile Silver coordinator, Amber Cook, is actually going to make a lateral move to iSmile. Beth Albright retired. We thought it'd be a good move. She could provide more direct services, and there's some unknowns with the iSmile Silver program as well. So we thought we wouldn't budget for that, just not knowing for sure if that was going to be a contract that would be in place come next November. And then as far as, give me a second.
While Jen's taking a drink, I just want to make a note that Jen and I and Shanna have worked on the wages together. None of these are including any sort of increase. It's just there's been turnover on the staff and hard to figure out who's on what line and all of that. So we've worked together to try and figure out those. But again, those 3 lines are not with any raises.
And as far as the clerk line, so we have had a lot of movement. Our previous operations specialist, resigned. We've, made a move for Shanna Fulton to step into our operations specialist position. By doing that, we don't have anybody to do claims. We also have moved, Megan Coking, who was our, basically dental clerk, in CSA 4 and 6, has stepped down from full-time to just a part-time position. She's willing to stay on for maybe 2 to 5 hours a week if she can make it work, just to help us get through this time. But we're essentially trying to combine 3 positions into one. We did have to unfortunately cut or eliminate a position. So with that position being eliminated, it's essentially taken 3 positions and putting it into one. And we think that we can bring in somebody from around a salary of 75,000 and bring in more in at a entry level at 50,000. So we think by combining those positions and then dispersing some of the work, that we felt we could eliminate a position. I guess that's kind of it for salaries. FICA, IPERS, Blue Cross. Those are all down. Obviously, we had a decrease in staff. Office supplies, we've got that around 50,000. Just found everything to get more expensive. We were basically told to anticipate probably a 5% increase pretty much across the line with any sort of equipment. So that's what we're looking at. Again, Crystal, per our request last year or whenever this was, maybe 6 months ago, really divvied out our office supplies, outreach supplies, dental supplies, and health supplies. It was kind of a catch-all, I think, before, and it was really hard to know where our expenses were. So we feel like we've got a better grasp on where that is by divvying those out, especially with the dental supplies, because they are very specific and are oftentimes expensive. The partial hospital medical, I don't really like the way that's labeled, but that's any other vaccines that aren't flu. It also includes epinephrine. So if there was a reaction to some sort of vaccination, those are typically pretty pricey, around $750 per box, which has 2 doses in it. Daniel Pharmacy is usually pretty good about floating us a deal there, but we've anticipated $2,000 in expenses.
Sorry, Jen, don't want to interrupt you. But,
No, go.
she has it labeled partial hospitalization medical. We have updated that. So I see some confusion and maybe some confusion in your guys' eyes. It is now listed in your workbook as non-flu vaccines, just to kind of clarify.
Thank you.
Thank you. And then, yeah, the next line is flu vaccines. Again, looks like we budgeted for 40,000. We think that'll be less next year at 30,000 and expenses of what we need to purchase. Okay, utilities. So there is the shed. I don't even know the address right now, but the shed over by the old Wakanza School. I know I shouldn't call it that anymore. We have been paying the bills for that gas and light insurance. We anticipate we're going to move out of the shed. We had a lot of emergency preparedness supplies in there. We're going to try to redistribute those, get rid of a lot of things that we don't feel like we need. And we hope to cut that completely out as any sort of an expense. My understanding is I believe the sheriff's department, they have been parking their vehicles in there as well and be looking at that as them taking over on those expenses there. Yeah, so that's why I've got question marks, but we'll be out of the shed hopefully, obviously by the end of this fiscal year. Office notices and publications, we kept that similar to 2,000. We anticipate higher expenses with postage going up and our required mailings with a lot of our grants. The employee mileage and subsistence, that one always kind of threw me off. You'll look at that, we're way overspent, and that's just because of that Suburban that we purchased. But we're anticipating expenses more around 25,000, similar to last year. And then telephones, we kept the same 16,500. School of instruction, we feel like that'll be a little bit less just because we no longer have the McBee grant, which required a lot of training and very expensive training. So we're hoping to see less there. Office and data equipment, I want to say we have gotten rid of an electronic health record that was with our home health program. We were stuck in a contract until June of just this past year. So luckily we were able to switch to the health record we use for public health. And that should cut about $16,000 a year by eliminating that additional cost, which was called Matrix Care. Tort and liability, we have pretty similar at 20,000. Dues and memberships, same around 60,000. Bioterrorism, 325, I guess that is pretty similar to last year again. And then miscellaneous expenses at 2,500. So again, that was at the 2,976,727.
Why were they giving us so much for bioterrorism back in the day? Like, what's going on here? I'd like to know.
Better than me. I'm I'm not really sure. It does seem to be a lot. And then on the flip side, we've noticed that even with having some of that money, a lot of the hospitals don't necessarily tap into that money. Hospital preparedness is more difficult. Obviously, a lot of the supplies and stuff they need is probably around more like 5,000 to 10,000. They're only allotted around $1,750. So I think a lot of times they don't spend that money. I couldn't probably agree with you more. I think we could look at those things a little bit different, save in specific areas and be more efficient in our emergency preparedness pieces. But that is a lot of money.
Seems like 1 million down to,
Well, and that was COVID. So
there we go. That's what I was wondering.
yeah, if you want to go back to that. Yeah, because we carried that contract too on the entire northern half of the state. And that
That was COVID.
was COVID.
Okay, thank you. I was wondering, that's a big drop.
Yeah, yeah, but it's still, it seems pretty high to me still, but it's at the same time, they were filtering, that's where I think there was COVID, the workforce development grant, and then the ARPA funding.
Well, I mean, if you've ever had that powdered envelope sent to you, you appreciate this, because boy, oh boy.
Yeah, it was a lot of money. Do you want me to go ahead and cover opioid quick and then we come back to public health? Or what do you think?
Talking with the slide deck.
Yeah, I was just gonna
We can probably go through that. I'd say let's do the slide deck now, while, since we're on that, rather than trying to circle back to things, and then we'll finish the rest of that out. If that works for everybody. Figured to save some confusion. There's always one no. I'm trying to save the back and forth.
An envelope with powder, I don't know, this is anthrax, and then you have to lock everything down. Oh, that's the worst.
There, does it look that way up here? Okay, so I just wanted to kind of explain the Board of Health split. So when we had the Board of, what's up? Oh,
Because, well, so when I shared it. Oh, it's just, no,
that's fine.
oh, it's on presenter mode.
Okay. Thanks, Austin. So previously, we've had this Board of Health split. It's basically a quarterly analysis that we make around our cost allocation and how much we're spending in each of our grants. What we found most recently here is that obviously we were looking at a Board of Health split of 20%. 20% of that was essentially not covered and needed to be covered by any sort of revenue source. And then as you go down, you can see the percentages per grant as far as what those percentages was. If you look to the right, we essentially looked at redistributing how we looked at the Board of Health split. Again, a couple of years ago, obviously we had a lot more revenue. We were giving COVID vaccinations. We had a lot more flu. Unfortunately, and we were doing the ASQs on every single kid. So we had a lot more revenue to cover a lot of our expenses. We don't have that obviously anymore. we also, you'll see in the old, the Child Health CSA 6, so the CSA 6 lines of Child Health Hawkeye and IS is I Smile and then Sealant. Those are not in-house. We've only been asked by the state to be the fiscal agent for that specific grant and only for oral health services. So as we were looking at that, we're like, why are we splitting those particular pieces of that grant when they're not even in-house? So some of those Board of Health split expenses were like paper and printers and different things in-house. We might look at splitting a little bit of that just because of the fact that we do the claims and that kind of thing. But as far as what we were looking at with the new Board of Health split, all of our staff, except our administrative staff, are essentially covered by either grants or a revenue source. Our administrative staff, unfortunately, like 20% again of that old Board of Health split was not covered. Like, for instance, my salary. And as we looked at that, we were noticing, so we'd have to put a Board of Health split on our PTO days or on our holidays, or the mandatory trainings that the county would have. So again, 20% of that salary wasn't covered. So by redistributing how we looked at that, obviously you'll see a Board of Health split only at about 1%. So obviously the revenue is going to be a lot easier to cover that 1%. Taking the CSA 6 that's not in-house and redistributing that Board of Health split just on the admin side, we're hoping will help bend the needle. I just want to kind of show you what I feel like that's going to look like. Let's see if this does this for me. Hopefully everybody can see that. You'll notice here in the last quarter, I was able to pull, this is my time, just so you know, in the last quarter, so was October through December. You'll see the Board of Health split at about 41% of my time. Looking back on that, it's a lot of holiday time, PTO time, again, mandatory training time. That's obviously very significant. Went back in this last month and you'll see hopefully this closing of the gap on the Board of Health to about 11.5%. And that was again, looking at just splitting out my time under that new Board of Health split. And then you'll see on the last 7 days, there's none. So none of the administrative staff should have any Board of Health split time that is not covered. Everything should be redistributed through every one of our grants. I will give you this example. So this is mine specifically. So we went and all the grants are over here, looked at, this is a distribution of how many hours in the last quarter. And then we did percentages of how much of my time was put under each one of those grants. So we based it on an 8-hour day. So specifically myself, when I'm working under a grant, I put it under the grant. So if I'm say doing maybe billing on our spots grant and it takes us a couple of hours, that's 2 hours and put it under spots, that's covered. We know that's covered. But immediately if I say haven't worked under any other grants, specifically for the day, I will then split on that 6-hour line, because obviously I work the 2 hours, I'll split the rest of my time for the rest of the day. That would be my Board of Health split. So we did this with Shanna, is very similar to mine, the operations specialist, but we did this with Anne Marie. Hers will only split like 3 times, and then like Erica's probably like 4 times. But I don't know if that's making sense by the way I'm saying that, but that is essentially how we went for this, from this uncovered piece to essentially everything being covered. Unfortunately, I think it was done that way, and having some new eyes on this has helped a lot, just to say, you know, why are we still doing it this way? It can't be this way anymore. So that's essentially why we should see in the next quarter, we have to do the cost allocation analysis every quarter. So if we have to renegotiate some of those with any of our admin staff, we'll make changes as appropriate. Questions on that?
I understand it.
Yeah. Right.
Well, one of the part of the discussion was, is like, are we allocating time, or are we like in the right buckets, or are we just putting it somewhere out of convenience? And, what might have been, there's gonna be a little more work involved with making sure we do this, but this helps us make sure that all the time gets allocated in the right places. So if we've got grant revenue streams that can cover some of this time, we can take that off that Board of Health split, so that we can kind of keep our portion of it down, but then also put people's time in the right bucket, so that if they're working under that grant, then the grant then should be paying for that versus us just paying for it because it was convenient to bucket there.
That would probably be this is more so our time, very specifically with our time, being sure everybody's time salaries are essentially covered. Yes, I'm sorry. Yeah, within that. So that would be kind of inclusive of all of it. Yeah. But essentially the biggest piece I feel like we were losing out of, especially like I said, with any sort of time off for holidays or mandatory county time, was not able to be captured, which now all should be captured. So hopefully we can see these losses essentially going away. There's always going to be some, obviously, with mileage. Obviously, the county pays more for mileage than what our grants reimburse is, only at 50 cents a mile. So we essentially lose 15 cents. We've come up with different strategies and talked to Austin about, we have a transit van that was purchased with ARPA funding. Further discussions with that. Do we trade that in? We can't sell it. If we sell it, it has to go back to the Attorney General. So that's kind of a wash for us. How can we, either as a county, figure out a better use for that? Working with the Sheriff's Department, there may be some opportunities there. It's just further discussions we need to have. Obviously, we always try to be sure any of our programs are using a vehicle specific, especially home health, because there's not a reimbursable rate for home health for mileage. So home health basically takes priority to use those vehicles. The biggest loss probably that we're looking at is in the CSA 6 area of the 9 counties. They cover 9 counties. We've asked the state if we could purchase a vehicle with grant funding. Pretty much we're told no, but we are paying probably per person there. I'd say 2 main people there, $800 to $900 a month just in mileage, because they have to cover so much ground. So that's essentially losing money. So we've talked about trading this van in, and is it designating that for that service area to save on some of these costs, and working with the Board of Health, obviously on some of those things to see where we can stop losing some of that money. So.
Out of the state house on having public health go to a state-run program versus the counties.
I keep hearing it's not going to be necessarily state-run. There'll always be local representation. I think what they're saying is, obviously the state would be the contract holder. They're looking at these regions. There was a lot of talk that it would align with the behavioral health regions. That kind of, they stopped talking about it in like the last year. But I foresee it most likely coming at some point. I just don't understand how it's going to work with contracts and competitive and boards of supervisors, boards of health, that kind of thing. So it's kind of, every time I'm on a monthly meeting talking of that, it's kind of like, well, we don't know. Yeah, we're not really sure yet. So the same things you guys are getting, I'm sure, is what I'm getting from any of those. So I don't know. Yeah, thank you.
That went into getting this done, a lot of time and commitment to try to best manage that money. So I'm appreciative for all the folks, Jen and her team, for going after, this was something that the Board of Health had talked about. And they really kind of grabbed this one, and we're trying to make this as efficient as possible for the county as well. So
There are safeguards in place to make sure that the grants aren't getting double billed.
Yeah, exactly. Yeah, this is, it's essentially just split through each, so they wouldn't have any sort of double billing of any sort. No. And it's obviously the payer of last resort. So if we have any revenue, obviously, we utilize that revenue before we would even be able to use any of that grant funding.
So Austin and Crystal, I don't know if you know, but they're early outing the schools. So just sharing that with you guys, since I know you probably might be affected by that.
And while we're here, are you fully staffed now?
No, we still have the registered nurse position that I was kind of talking about with the CCNC program. And then the other piece of that would be mostly WIC. And then other opportunities, obviously with the multiple other grants that we have. And then this new administrative / dental program assistant. So again, that was that 3-in-1 kind of inclusive position that now we would have open by combining all those positions. Hopefully with the opioid work, probably need Crystal over here. And then we're hoping that the person that we had to eliminate the position did a lot of that opioid work. We're hoping that can be absorbed with Erica, our general lead person, to kind of take that over. It's just a lot of learning curve stuff with that opioid funding.
Okay.
Is this the right?
No, you have to slide to the left. And then,
And slide to the right.
I was just gonna say, I was just thinking that same thing.
oh, I felt like when I said that, somebody was gonna.
Uh-huh.
You know, we were
Like you
gonna
didn't
do
know who was in.
a dance off. Dance off.
Okay, so the last budget that we provide some oversight to is the opioid settlement fund. Essentially, we pretty much moved a lot of this like we did last year. It is in an interest-bearing account. I can't remember when that happened, but we did account for 10,000 in interest from the opioid settlement and just budgeted for the 180,000. And then as far as our expenses, we'll work together, I think, to get this more understandable in the line items, because I don't know that the names are necessarily appropriate for what we're utilizing this for expenses. I'll kind of inclusive it. So right now we're in an agreement with the sheriff's department to pay for the drug task force deputy at 60,000 a year. I'm assuming that's coming out of the other treatment prevention and other strategies piece. And then each year, I'll mess up these acronyms, but with 911 dispatch, we're paying for the EMD cards, that kind of thing. So we'll have annual fees. We'll be kind of looking at, we've diminished the subcommittee, opioid subcommittee, and kind of because we felt like there was a duplication with the subcommittee. So the Board of Health is essentially kind of taken a lot of those pieces on. So when we have a proposal, there's an application process for people to put that proposal together and with how much funding they think that they'll need. And then that's brought to the Board of Health to decide if that's something that's going to be funded. So, yeah.
We found we were meeting twice for the same thing for the
Right.
most part, so. Figured instead of. Because we really didn't have, and that's, I mean, I get why we did it when we first got started, but the more we looked at it is, we would meet, we didn't really have a structure, so there wasn't like voting, we just had to talk about it, and then it went to the Board of Health, and so we said, well, why not just, let our admin staff help get everything pulled together and then bring it into the Board of Health, and we can talk in there, so.
All opioid funds do stay in that account, so they're we're sitting over 500,000 as of Monday in the opioid between interest and whatnot. So even when we do adjustments, because if somebody brings in more requests, proposals, all of that, there is funding currently for it. It's not coming out of like the general fund or anything.
That's money's supposed to keep coming in until 20, 30 something. Yeah, it's over like,
Seems like a ways out, but it probably isn't,
yeah.
As long as it's proven that we're using it for opioid funding, and there is a report that I know Deb and I were working on, and I need to go work with Erica on as well, to try and get that finalized for last calendar year on what funding was done. So.
That was going to be the next question. What kind of stuff we kind of-
Gosh, we've a lot with the sheriff's department. So those EMD cards, there was fentanyl test strips that we did. There was I don't even know what it's called, some sort of a hands-free like gun where they could look for drug residue on like the outside of a package, so there'd be no risk, for touching that. What else did we did? Drug task force deputy, we did the, canine. I think there were 16,000 that we accounted for that. I know I'm missing several things.
Good job right there.
That's gotta be.
Is there anything by way of prevention? Or is it more mitigating risk for law enforcement? at the
It's
moment?
probably been more mitigating thus far. There's opportunities, though. Essentially, everything that is presented, we have to just relate it back to, it's called Exhibit E. But there are different components of prevention, mitigation, treatment pieces within that. It's somewhat vague, so it's hard to get clear direction as far as, it looks like somebody says it's covered, and then you're kind of like, some reservations of like, is it directly related to opioid? And then there's,
Yeah.
verbiage in there of, mental illness as well. So your co-occurring situations, but then it's like, okay, well, can be opioid. There's a lot of gray is
I bet,
basically what I'm
yeah.
saying. It's hard to decide that. So
I would imagine that you would have a situation where there would be maybe multiple events of substance abuse. And so how do you differentiate an alcohol abuse versus an opioid in the same?
exactly, it's sort of
Yeah.
like a diagnosis that they could have somewhere down the line opioid diagnosis, but maybe the methamphetamine usage or something along the lines. So can you relate that? Even vaping has been one, like vaping's not necessarily opioid, but there's that fine line in the middle of, could you use opioid in a vaping situation? I mean, there's just a
Yeah,
lot of different, it'd be nice if there was a lot more clear direction on that. So we're working through it, obviously. Supervisor Hikes worked with us a lot on that as well, trying to delineate what can be used for those funds. So, and we do put our staff, when we are working directly with, say, budgets or whatever the case may be, we're able to bill our time once again to the opioid funds for, especially with the subcommittee when we had that with a lot more time, and that we'll probably have a lot more now that we don't have the specific employee that was working a lot with that. So that'll be kind of divvied up with some staff too, which is helpful for us, but obviously we want those funds to go back to the folks that obviously need it. So
Any questions on that? Thank you. Appreciate it.
thank you guys. Thank you for listening.
All I did was hook your computer up.
Now can I just like leave?
Just, yeah, you can, yeah,
Like I leave, but leave,
yeah, yep.
Oh, that thing? Okay. Okay. Sounds good. Okay.
The precedent's been set. You gotta have a slide deck, so.
Yeah, did you bring?
Let me